And great. So welcome to Talking Data Equity. I am Heather Kraus. I'm a mathematical statistician and the founder of an organization called We All Count. And We All Count is devoted to finding and building practical tools and resources that can help anyone align their data work with their equity goals. One of the things, really one of my favorite things that We All Count does is this informal Friday series called Talking Data Equity. And this is just a place where anybody who's trying to put into practice anything to do with equity and data can get together and share ideas, share successes, ask for help, and feel not alone. So that's what we do on Fridays. Sometimes we have a specific topic that we talk about, like sampling or weighting or how to collect demographic data. And sometimes we have a special guest. Today is one of those great days where we have a special guest. And so I'm going to introduce our special guest and then turn it quickly over to them so that we make the most of their time. But quick housekeeping reminder is that we continue to run this as a Zoom meeting, which means that any of you can unmute yourselves at any time. However, we ask that you don't do that. We really would like it if you would, during the time that our special guest is doing their presentation, that you feel free to ask questions and make comments, and that you do so in the Zoom chat. And you can use the Zoom chat set to everyone, and that means your comment or your question will be publicly seen, or you can direct chat me if you want to ask a question that you would like me to amplify, but you don't want to use your name in public, no problem. Then after our guest is done talking, we'll move into the live Q&A, and that's when, if you want to unmute or put on your video and ask a question, you just raise up your hand and we'll get to you in order. So that's the housekeeping. And let me say how excited I am. I have gotten this week to prepare for this, and the work that Dr. Jessica Cerdeña is doing is amazing. Dr. Jessica Cerdeña is coming to us live from New Haven, Connecticut, where Yale University is. And they are a medical anthropologist who studies the biosocial underpinnings of health disparities. How cool is that, right? I'm going to let them tell you about their work and what they're thinking and doing, because they'll do it much better than me. But I just really want to put in a quick plug at the beginning, which is I highly recommend reading everything they've written. We'll put links to a lot of those things with the video on our Data Equity Forum. And there's a book that's coming out soon called Pressing Onward, The Imperative Resilience of Latina Migrant Mothers. So that gives you a quick taste. I'm going to turn it over to Dr. Cerdeña, and thank you so much for coming. You can tell we are so excited to have you join us today.
Thank you so much for this opportunity to be able to speak with all of you, because for me, I straddle these two worlds. I call myself a bit of a double agent as a medical anthropologist and also as a clinician. I am finishing my medical degree, but I have a PhD in anthropology. So I straddle these two worlds where I get to think as an anthropologist and think about kind of people in their social worlds and social contexts, but I'm also out in medicine. I am literally like coming to you from the hospital where I am prescribing medications and seeing people put into practice evidence-based guidelines. And that is where you all in the data world are kind of informing our practice every single day in every clinical encounter. So for me as a medical anthropologist, I always think about kind of what is going on in patients' lives before they get into the hospital, and how all the different ways that the policies that we have in place, the stigmas that we assign, the ways that our society is organized shapes all of those things that people carry in with them when they come into the hospital or into the clinic. And then also how those interactions in the clinic and in medicine are shaped by all the things that we as providers carry in with us. But what I want to talk to you today is about how we in science and as researchers and in data carry our own freighted perspectives that are very much imbued with the different experiences of being entrenched in structures of white supremacy, of racism, and how that can shape what we do and how we practice. So I would like to share some slides that I have prepared. See if this works. And so I will talk to you about race-conscious medicine and data equity. And that's some of my information if you want to follow up. Are you able to see everything? Good. Okay, perfect. So race-conscious medicine. What is race-conscious medicine? So this is a term that my colleagues and I developed. We put it out in a paper in the Lancet that came out in 2020, and it emphasizes racism rather than race as a key determinant of illness and health. And you might be thinking, well, sure, that as I understand from this audience, we kind of accept that racism is a thing, and that is what drives these health disparities. But I want to give some context as to why we felt this was needed. So we proposed this figure because we proposed race-conscious medicine as a contrast to what we saw widespread in medicine, which was this idea of race-based medicine. The idea of race not really having a good definition. We use it all the time, but no one was really explicitly naming what we were talking about. And it was always inferred to have some kind of biological or genetic significance. And when that happens, in research, we have these epidemiologic studies these clinical studies, whether it's kind of like a clinical trial or kind of case studies or things like that, that are kind of studying some phenomenon, either on a public health level, an intervention study, or kind of a pharmacotherapy that links race with a disease process or an outcome. Or even kind of going into the lab and saying that we have these basic and translational studies that link race with these biological processes or phenotypes. And then in medical education, so how does that affect what we learn? It means that we understand that racial groups are inherently diseased, and these biologized concepts of race are reinforced. So we basically learn in medical school that kidney disease, that heart disease have differences in how they present in Black patients versus white patients, in Latinx patients, Indigenous patients, and so on. And then that changes how we practice. We have evidence-based guidelines. We look at resources like UpToDate and Dynamed and so on, and we follow what comes out in the United States Preventive Task Force recommendations, or what comes out in the Journal of the American Medical Association. And we see that that's what we should do. And that leads to bias and stereotyping because we are practicing based on these race-based guidelines, and we tailor our clinical practice according to race. And that actually exacerbates some of these racialized health inequities that are resulting from kind of these larger sociostructural forces. So our alternative is race-conscious medicine, which we actually understand race as a social and power construct that's resulting from the practice of hierarchizing humans based on these preconceived ideas of these ways that people should be socially stratified, not based on inherent biological difference. In research, we would instead analyze the effects of structural racism and white supremacy. We would look at how racism actually affects health, rather than presuming that there are innate biological differences. And then in clinical practice, we would try to seek to intervene on that and provide support to kind of counter the effects of structural racism and modify how we as practitioners and medicine as an institution are actually participating in propagating some of those harms. And the idea being to kind of mitigate some of those effects. The important thing to consider here is that science is not neutral. Science has never been neutral. Science is actually very much shaped by our partial perspectives. And this idea that when we are pursuing this elusive objectivity, that is itself a reflection of our own bias. Because no matter what, the question that I ask now in this point in time is going to be shaped by the information that I have. And the information that I have is shaped by me and the things I pay attention to as an Italian Chilean woman coming from Yale University, being in the United States in 2022. By contrast, Johann Blumenbach, a 18th century German physician, looking at differences in skulls that he perceived, very much shaped by his position as a German physician in the 18th century, seeing differences that were coming out and how what was going on in processes of imperialism, European colonization. And so when he proposes that there are differences between a Caucasian skull and a Mongolian skull and an American skull, referring to indigenous people in the Americas, this is very much informed by his perspective and what is occurring at the time. And so these social factors and what is going on politically very much shapes what the imperatives are and the questions that we ask. So I think it's important to say that, like, the scientific method, the idea of forming hypotheses, research questions, testing them, accumulating evidence, actually the whole idea of Enlightenment thinking converged with colonization. And this is not to question the scientific method. I think that it is really important for how we investigate things. But even that process, we want to think about at each step, how can we be critical of what is going into those judgments? How did we come up with this hypothesis? What informed this research question? What data points are going in, and what are the things that we count as observations versus what we disregard? The other important thing is that when it comes to the point of medicine, clinicians are going to point to the summary statement. What is the guideline? How is this going to affect my clinical practice? All of those preceding steps of all the different assumptions that went into the model, the raw data, we were talking, Heather was mentioning earlier about like the weights and the, population and all those different considerations. We don't get to think about all of that. We're relying on someone else to have done that. So we have to put a lot of faith in the process, and a lot of times the process is flawed. So you've heard of garbage in, garbage out. I say racism in, racism out. So it's important to take into account. So what does race-conscious data science look like? First, thinking about racism as an exposure, thinking about how we can operationalize racism as a concept. It may be measuring over-policing, incarceration, wealth. We know that all of these have disparities, and these are results of white supremacy and the consequences of a structural racism. But very infrequently do we actually measure them. What we do instead, or we think about, well, just race will capture all of that, or even kind of really gross measures of social difference like socioeconomic status or class, and those are really imperfect, and I think that we can do better. We want to avoid thinking about race as a proxy for genetics or broad measures of social experience. Even saying that we focusing just on experiences of discrimination, that only focuses on one part of the experience of racism, of the interpersonal discrimination. We want to think about things much more broadly and on a structural level. We can think about the experiences of policy change, like what does it mean to have the baby bond program, and how is it actually changing or not doing enough to change wealth disparities in between Black families and white families. We do want to keep track of demographic data. We want to track race and ethnicity and other kind of measures of racial difference to be able to evaluate equity and the impact of interventions. That's important. We're not saying that we want to take a race blind approach. We want to be race conscious. We know that race matters for how our society has organized itself. So we need to keep track of these data points. The question is how we use them. We want to make sure that in our data sets and our study participants that we do have representation and diversity. This is important from an equity perspective. This is important for ensuring confidence from people who have been excluded, marginalized, oppressed. Because if they're not included, if they don't have a say, they don't have representation, what does it all matter? Like, we can't just say that this is valid and important because we did it in a bunch of, old white guys. That's not actually saying that this is getting at the questions that we need. Again, we want to be race conscious, not race blind. So we want to be mindful of having this representation, but it's not because we are presuming that there's inherent biological difference. We are recognizing that there is a whole bunch of different things that are captured by differences across experience, and that our society has structured itself in this way. So we want to make sure that we are doing this from a data perspective, from a confidence perspective, and from a representation of the heterogeneity of experiences that people can have. And we also want to make sure that in all of these processes, we are centering people with lived experience. So in our participants, in the people who are involved, that they are part of the table, that they are part of either on our study teams or in the part of, the community partnership, and being involved in what questions we ask, how we ask them, how are we collecting these data, what do we do with it? Like, what does our data matter if it's just going to go to some report, to some company, or to an academic journal? How is it actually going to change lives? This is what we always want to be asking ourselves. Like, how is it actually going to make a difference for somebody who is affected, who has skin in the game? And the last thing I want to say is that we need to end scientific racism to be able to achieve health equity. And this is why I think this conversation on data equity is so, so fundamentally important. And with that, I would love to open the floor to questions or comments or pushback, anything that would be valuable and helpful.
Yeah, well, thank you so much. That was extremely valuable and helpful. You can all now see why we're so excited to have Dr. Cerdeña join us, because we're all here working in our own kind of sector, in our own part of the world, on how to grapple with the reality that science is not objective, exactly what you just said, and how to do actual work once you start believing that in your area of control. So there are questions coming in through the chat, which I will amplify. But before that, I just want to see if anybody who's here in the room wants to raise their hand and ask a question. Either you can unmute yourself, or you can come onto video, whichever is more comfortable for you. And I will give you a couple of seconds to decide if you want to raise your hand, and then I will start reading questions from the chat. And again, a reminder that you can ask questions in the chat with the drop-down menu set to everyone, or you can just ask chat to me privately. All right, so of course, there is one question that has already been in the chat by like 11 people, which is if you go back 2 slides, or to the slide that has the numbered steps that you outlined, which was I think quite okay. So measures racism as an exposure in a way that avoids using it as a proxy for genetics is something that the commenter is familiar with. However, do you have any ideas about how to measure racism as an exposure without using social experience? One of the things that we have tried in the We All Count community is to use Dr. David Williams' work on, like a racial discrimination scale, so that we're not using somebody's administrative race category as a proxy for experience of racism. We've tried collecting that kind of data, like experiences of discrimination data, and then either using that on its own or using that intersectionally with race, so that we're not like homogenizing the experience. Do you have any thoughts on that? I don't, not on that specific scale necessarily, unless you do, but on how else to measure racism other than experiences of discrimination?
Yeah, so I think it's challenging because it depends on the type of data that you're looking at and what your hypotheses are. So one thing is that Dr. Williams' studies are more at the individual level, where it's like experiences of discrimination. So the everyday discrimination scale, or the perceived discrimination. So those are looking at kind of like, what is your perceived discrimination? And then there are also kind of measures of internalized racism that he has also kind of been working on with his collaborators, that have been kind of validated and so on. Those again are looking at things on an individual level. I think that the other part of this is looking at measures of racism that are more broad. So this is more kind of if you're thinking about doing a population health study where you're curious about what is the effect of, let's say, uh, like a particular policy, like, Georgetown University wanted to do reparations for the Black community in DC area or Georgetown, like descendants of enslaved African people. Like if you wanted to look at the effect of that policy, then you could look at an effect of a health outcome. So that's like thinking about a particular policy. You could also, by contrast, look at the experience of a particular type of racism. There have also been measures of composite scales that have looked doing kind of like latent class analyses with different kind of inputs. I'll point you to the Moore lab, Rachel Hardiman's lab in the University of Minnesota, the School of Public Health in the Population Health and Health Policy, I believe. So they have actually looked at more composite measures that's looking at more, again, at population health data. So they actually came out with a couple of papers that were looking at metropolitan and neighborhood level structural racism. And then there also have been some measures of structural discrimination at the state level that's done by Professor Dean at Hopkins, I believe. So those are measures of racism that are less kind of at an individual level. And the point that I want to distinguish between 1 and 2, one is talking about racism and one is talking about race. So racism is, I believe, has different levels. So we can talk about individual interpersonal levels of racism. We can also talk about institutional, and structural levels of racism. Those are occurring at different levels, and they're obviously mutually constitutive and informative and co-produce one another. But if the everyday discrimination scale is talking about the interpersonal level, but that may miss experiences of structural discrimination. So I think that it really depends on the questions that you're interested in and the hypotheses and the data set that you're working with. But I hope that gets at a little bit of some resources and some ways to think about this and approach it.
It absolutely does. Thank you for that. I'm gonna more and more messages are coming in about this. So I think we're gonna stick on this topic just for a little bit because I think we're close to understanding. Thank you for distinguishing that number 1 is talking about racism and number 2 is talking about race. And so if I heard you correctly, let me ask if I heard you correctly. So if we stick with number 1, measuring racism as an exposure, one of the things we want to pay attention to is, are we talking about what level of racism are we talking about? Individual, interpersonal, structural, contextual, and that some of the resources you pointed to have figured out like a way to combine almost like contextual level data into a composite measure of racism. And then they use that composite measure of kind of, I'm going to say environmental racism, not in the idea of like the natural environment, but like the policy, social environment. And then they look at relationships between that composite population level measure of racism and population level outcomes. Is that what you're saying?
Sorry, I was unmuted, but yes, that's exactly what I'm saying.
Okay, great. Fabulous. So that makes a lot of sense. And Anna, this is a question from me. This isn't from the chat. Because one of the things I'm very interested in terms of building models is the combination of using models that combine individual level factors and then contextual level factors, so we can kind of look at the relative influence of those. Are you aware of that happening anywhere? That they're combining like measures of at an individual level and at a contextual level?
Yeah, so it's very funny. I was actually just reviewing a paper that was doing this in terms of looking at the different outcomes in COVID waves, that was looking at municipal level data, but was stratifying based on uh, uh, populations. So they actually kind of were, it was, it wasn't necessarily the way that I would have done it, but they were basically defining municipal level exposures. So they were looking, it was a paper that was done in New Jersey. So they were looking at what was the proximity to New York City, and what was the like density of like certain kind of thing outcomes that had been associated with COVID, of like income, class, education, different things like that. And then they were looking at basically the percent of the population by certain racially and ethnically minoritized groups, and then we're kind of classifying them based on if it was like a predominantly Black neighborhood or if it was a predominantly Latinx neighborhood, because there were high rates of segregation between the two. And then they were trying to see if there were differences, and they were basically trying to combine looking at these like municipal level exposures, but they were had the individual level that they kind of up categorized into individual to a like municipal level, if that makes sense.
Yeah, it does.
And then the other thing that can be done is if you use, larger data sets, and I'm more familiar with the US rather than outside the US,
Yeah,
but
that's fine.
you can have a primary like variable, which is kind of like a composite measure of structural racism, like whether it's at the state or at the like metropolitan statistical and
Mhm,
level,
mhm.
and have a composite measure, but look at individual health outcomes. And you do kind of like whether you're using like
Mhm.
Burfus or NHIS or NHANES or something like that. So the health outcome level is at the individual, but the measure of exposure, so to speak,
Mm.
is done kind of at the population level. I'm not sure if that
Okay.
also makes sense.
That does. No, that's exactly the question that I was trying to ask. So that's really, really helpful. Thank you. So speaking of COVID, I'm going to ask another question from the chat. Speaking of COVID, um, we are trying to make sense of health unit data that only has a measure of race. We don't have a measure of racism. And we want to talk about COVID, and we want to find a way to break out the data in a way that can talk about an exposure to racism rather than exposure to race. In other words, we want to say that, I'm going to a little bit rephrase this, but X% of Black people in our health unit got COVID, X% of white people in our unit got COVID, X% of First Nations people got COVID. There's a long list of races. But what we want to say in our messaging is that X% of people who were exposed to racism got COVID instead of Black people, because we don't want to double down on the stereotyping. We're getting pushback from this because our managers are seeing that we're making too big of an assumption that if we use the administrative category of Black as a proxy for exposure to racism, that is an untested assumption. However, we think that using the disaggregation as Black is as a quote unquote race is also an untested, actually a tested and incorrect assumption. Do you have any ideas that can help us? Does that make sense to you? I tried to
Yeah,
like rephrase it. It's a long question. Okay, great.
yeah. I have two thoughts. One is the guidelines say that when you're using data on race, that you should specify whether it was investigator assigned or like whoever collected this data, if it was like a public health administration or a clinician or so on, or whether it was self-identified. I generally favor self-identified categories, but if this was investigator assigned, that actually supports your argument that is an experience of racialization. Because that person is perceiving them as being of another race. This happens in the hospital all the time. People in registration won't necessarily go through and ask all the demographic questions. They will like write them down and be like, okay, clearly this is a Black man, and then like check it off, and then somebody can correct it later. But just for the speed of going through it, they'll just check it off. People are getting better at that, but historically that's how it's been done. So if you are able to specify whether it is self-assigned or investigator assigned, that can clarify how you can approach it. The second part of it is you can think about whether you want to, how you want to organize your data. So generally, it's best to disaggregate when possible. But if your hypothesis is that people who are racially or ethnically minoritized in some way have a specific experience with COVID, that could be an indication to aggregate. So you can have and do both, like show the disaggregated and the aggregated, but to be able to potentially demonstrate, and I don't know what your data show, but to potentially demonstrate that there's a difference between people who are not minoritized or advantaged, racially advantaged. Would be a potentially an argument to say racially advantaged versus racially disadvantaged, or racially centered versus racially minoritized or marginalized, and see if there's a difference that way, in addition to your disaggregated data, to be able to advance and support your argument that there is a factor that's an experience of racism. Again,
Okay,
this
that
is me
is
saying this not as a statistician, but kind of from the theoretical standpoint.
yeah, no, that's great. This is super, super helpful. And I want to throw in another thing that really helped, because this is an ongoing conversation, of course, and it's a very serious struggle at the practical level right now to figure out and to get it through all of the various people who have to sign off on written communications, about trying to flip the very strong habit of saying, yes, yes, we understand this is racism, it's not race, and then communicating about it like it's about race. Fantastic example that Dr. Oh my gosh. Sorry, there's a bee in my studio. A gigantic bee. I'm in Toronto and it's getting cold, so they're like trying to find some place to sleep. Anyways, fantastic example that Dr. Cerdeña had shared. You're going to have to help me about which article it is, but you made a point that said at one point during the pandemic, people who lived in South Dakota, which is a state in the United States, and people who lived in Vermont, which is a very far away state in the United States, the people in Vermont had really low rates of COVID, and the people in South Dakota had really high rates. And you didn't ever see anybody say people in South Dakota are high risk and people in Vermont are low risk. Like, I thought that example really helped me break through and have some conversations with people that said, like, yeah, so substitute, instead of black and white, substitute a geographical name. And it actually worked and helped a couple of people say, oh yeah, right, we would never phrase this report like that because you sound ridiculous. And
Yeah.
it's because everybody knows it's because, well, there's some policy, and the immediate question is, well, which policy is working in those geographies? And we would like to have that same focus when we're measuring differences. Okay, another question in the chat. How are we to interpret the news data that gay people are at risk for monkeypox? It sounds so much like the 1980s and 90s with HIV/AIDS. What questions should we be asking to understand the validity of what's going on?
Oh, I love that question. So many thoughts on this. So first, the big point that I always want to come to is center people with lived experience, because we have seen the huge drop in monkeypox in the United States because of people in the gay community mobilizing and being activists, exactly like what happened in the 80s and early 90s with ACT UP and citizen science movements and patient activist movements, saying that people needed to get, the treatment, and that this wasn't just like a terminal illness, and the shows the role of stigma and people who are considered dispensable. So we've actually seen that with this particular outbreak of monkeypox, unlike prior breakouts of monkeypox globally, that this does seem that these lesions have been mostly related to sexual contact, and that it has been less transmissible among people who are close, like personal contacts and so on. Although that has been the case. So it seems to be like direct contact with lesions, and that it has been more like genital, oral, self-inoculation with lesions and so on. But what has happened? We had a rapid kind of mobilization of vaccines, like in New York City, pretty much everyone who was very high risk, who was conscious and motivated, has been getting vaccinated. We've seen a huge decline. There's been a lot more promotion of barrier protection for sexual contact, and we've seen a drop. So that's still the point, being like, what is the discourse that's circulating and who cares? So the important things to note is like, do we need to talk about this as a gay disease? Absolutely not. That is not helpful. That's kind of language being stigmatizing is not going to help people. What we do need to pay attention to is, because what does that do? It stigmatizes people who are identify with a particular sexual orientation, doesn't emphasize what is actually transmitting the disease. What transmits the disease is genital to genital contact and manual genital contact with people who have active lesions. So emphasize exactly what is the mode of transmission of this infection. That's what we need to be talking about, because we don't want to cause unnecessary scare. We also don't want to unnecessarily stigmatize people. But we also don't want to inappropriately alarm people who are not going to be at high risk. So example that I give, I have a toddler, and like 2 months ago, everyone was breaking out with enterovirus, which is Coxsackie, like hand, foot, and mouth. And I was getting like texts of pictures of little things from all of my friends' kids being like, do they have monkeypox? And I was like, no, this is not monkeypox. This is almost certainly hand, foot, and mouth. So if we don't actually name like what is transmitting this disease, then you have all these paranoid parents who are like, my child has monkeypox, they need to get on an antiviral for monkeypox, when really they just need to be at home and, not get other people sick. So just naming specifically what's going on rather than these like totalizing labels. That would be kind of what I would talk about. And again, centering people with lived experience, because they could exactly tell you like, I had these are my symptoms. My partner got it, but no one who I lived with got it, unless they were like rubbing up on my skin.
Very, very helpful. So it sounds to me like a continual emphasis on being as specific and transparent as possible about actual cause, and actual salient context, whether it's monkeypox or disparate outcomes in healthcare, rather than accidentally just trying to shorthand attach them to various social identities that ends up just doubling down on stereotypes for those social identities.
Absolutely.
Okay. Super interesting question that I hope you can answer. Like it. This is a very interesting question. I have come here today because I have read your work on the overprescription of diuretics to Black people in emergency rooms. I hope that you are the right person. Has progress been made around this? And as a Black healthcare consumer, can you offer any practical tips on how I can take care of myself walking into an emergency room?
Yeah, so I'm presuming you're talking about my article. We're talking about the pathways and prescription for antihypertensives, blood pressure medications. So I think this is a really fraught challenge. I think that, so just to provide a little bit of context, the 2014 JNCH, so the Joint National Commission, 8th Joint National Commission for blood pressure recommendation, basically has a bifurcated pathway in the algorithm for treating high blood pressure. First being lifestyle modifications, second line, starting on a broader kind of high blood pressure regimen, and then kind of breaking it up between white folks, actually Black folks and not Black folks. And that was based on a systematic review that was done looking at different trials, and found that there were, for very specific outcomes, particularly ischemic stroke, that based on moderate to low quality evidence, there was a no mortality benefit for starting ACE inhibitors and angiotensin receptor blockers, which is a certain class of blood pressure medications. So those blood pressure medications were not recommended in this group of folks, and were recommended in other groups of folks. And for that reason, the diuretics are much more likely to be prescribed among Black folks. And a lot of that actually relates to racist ideas about the etiology and the pathogenesis of, or basically the underlying reasons that high blood pressure exists in Black folks, which is this salt slavery hypothesis, basically meaning that people believed that there is a genetic mutation that was a selective advantage for Black people who were descendants of the enslaved folks who came along the Middle Passage, that if there were so many people dying of vomiting and diarrhea, that they must have been able to have a higher ability to retain salt to maintain their blood volume. And for that reason, they would have survived while so many other people died. So many flaws with that hypothesis, going back to just kind of the Middle Passage was not a singular event. It was many people over hundreds of years who came across this way. That kind of just misunderstands how population genetics and founder events work. Also, we can test for this, and that is not what the tests show. We don't see kind of a selective advantage for kind of salt retention. Also, the Black population in the United States now is very admixed, and we see a lot of genetic variation. So there is no reason to believe that there is kind of like one gene that's driving this phenomena. And it's much better explained by racism and kind of experiences of chronic discrimination, and diet changes and all sorts of things that have just become imbued in social experiences, cultural experiences, and so on. So many things wrong with that. So the one part of that is why all that happens, why it's problematic. I think that there is, I hope, some shift in culture. I think that as I talk to medical residents now and medical students about this problem, people are a little bit more cognizant of the issues with that particular recommendation. And the American College of Cardiology and the American Heart Association don't have a specific race-based guideline in their more updated recommendations, although they don't kind of push back on those 2014 guidelines. So it's kind of still out there. So it's interesting to hear how people will still say, well, that's the evidence-based recommendation. Then when I have these conversations, I'm like, well, did you actually look at the paper that it came from and kind of talk about and so this is again, the importance of scrutinizing the evidence. To talk about the importance of how this impacts patients' lives, which I was saying in the presentation, we have to think about how this impacts patients' lives. I think that it's always important to be an advocate for yourself, be an advocate for good quality medical care. And I recognize how stupid that sounds and how hard that sounds, because when you're a patient and you're talking with a doctor or any clinical provider, to be able to say I disagree is sometimes really challenging. But be able to kind of ask the right questions, why this medication? What are the benefits? What are the risks? What are the alternatives? Do I need to make this decision right now? Can I look it up and try to figure it out later? I say this to all of my patients when they're trying to make a decision or choose an intervention, because I have information about the medications, but they have information about their own bodies and how this is going to feel for them. So a lot of times, like starting a blood pressure medication, not something that needs to be decided right now in this clinic visit. Truthfully, not. It can be something that we can schedule a follow-up in 2 weeks and 4 weeks. Oftentimes, unless it's like a crisis situation, we don't have to make a decision. And you can take the time to think about it and think about and do research and decide. So I think that whole part of like recognizing that, yeah, the clinician has the experience of having gone to medical school or PA school or nursing school. But as a patient, you've been living in this body for however many years you've been living in this body. And that is valuable knowledge and expertise. Like we're bringing something each to the table.
I really, really love that answer. And it makes me think because, I hadn't read your specific article on that topic, but I have read articles that are more broad based. A few I think there's an article, I don't remember its exact name, but something like what's race got to do with it, that actually catalogs a number, and like lots, like more than a dozen, quote unquote, evidence-based decision trees, like the one you're talking about, that do kind of recommend that health professionals make different decisions based on race, that turn out to be super problematic. And that's in academic literature, like I've downloaded that from some, university library or something. Are you aware, or is anybody here aware of any information that is kind of crafted and communicated for a lay person, that is like, here's a list of algorithms that are still in use that involve race, that you should stop and pause before you necessarily take advice from this? Are you aware of anything like that that exists?
I can say that the Institute for Healing and Justice in Medicine is a collaborative of clinicians that are trying to provide information both for patients and for providers to be able to counter this. The goal is ultimately to end all of them. But in the interim, to provide information for clinicians who want to counter this with their teams, to kind of put a stop to and kind of question, like, why are we actually using this algorithm? Like, is there a better way of thinking through this, but may lack the vocabulary and the evidence that is going to counter it in these kinds of conversations when decisions are being made in the hospital and in the clinic, but also to provide like one pagers for patients. The repository is not complete yet, but the website, I think it's like IHJM. I can, if I put it in the chat, will everyone see it? Or maybe I
Yes.
can just send it a follow-up of resources.
Yeah. We'll add it. Don't worry. We'll add it to, when we post this video, we'll add all the resources.
Okay.
We'll find
It's
it.
the Institute for Healing and Justice in Medicine. So that's a place that I would recommend kind of following through, because it's constantly being updated. I'm kind of part of the collaborative there.
That's great. I did not know about the Institute for, did you say Justice and Medicine?
For Healing and Justice in Medicine.
In medicine.
IHJM.
Okay. Great. Institute for Healing and Justice in Medicine sounds like a fabulous thing to look up. Thank you. That's a really good resource. Okay, we are almost done, because we don't like to go right to the top of the hour, because we know lots of people have back-to-back meetings. So I still have like 8 questions from the chat, and I will pick the most popular one. Oh, thank you so much, Karina, for already finding that for us. But does anybody want to unmute and ask the last question in the room? And otherwise, we will go to the chat. All right. So a couple of people have asked about specific data sets, and I don't want to put you on the spot, because of course you can't be an expert on all the data that exists, but I'm going to just use one of the specific data sets as an example, because I think it's a kind of a broad enough question that we can talk about the concepts without really knowing about the specific data set. And that is, I use publicly available Medicare data to study and track post-discharge events, the percent of people admitted within 30 days following a hospital discharge. So essentially, this person is looking at how many people that get discharged from hospital have a very quick turnaround that go back in. And these data are often, they often come to me having been standardized by race, or the best practices, I'm expected to standardize them as race. I've become uncomfortable with this, because I think it probably is then embedding and replicating racism in the results, Do you think that's right? And again,
Yeah.
I don't want to put you on the spot about this particular data set, but in general, what do you think?
No, I agree. I think that that's a really good gut check. And I think that, again, it depends on what your hypotheses are. I think that, when you're talking about readmission, again, think about all the things that structural racism can play a part in. Like, what is the kind of follow-up care? What kind of social environments are people returning to? What kinds of chronic conditions and comorbidities are people coming in with that are going to make it harder for them to be able to get the necessary care following up? Like, if somebody is coming in with heart failure, kidney failure, and then they just happen to have a skin infection that they needed, IV antibiotics for, they're going to get treatment for their skin infection, but they're still going to be going out with heart failure and kidney failure. And we know that heart failure and kidney failure are more likely to happen in people who are experiencing structural racism. We see higher rates, particularly among Black men. So yeah, like, those are things that I think about. And when you're having conversations with these collaborators, like, I think that those are important to have. And also I would ask, like, kind of what other data do you have access to, and what other ways are you able to kind of account for these things? Because if it's Medicare data and you're looking at the entire country, it might be harder to account for kind of like broad experience of structural racism on the level of the entire country. But if you are able to kind of drill down a little bit, and maybe this is for one hospital system, you can think about things like, do you have patient zip codes? Do you have, neighborhood level structural racism measures? Do you have are you able to incorporate, if it is kind of at the level of an MSA or a county or a state even, can you have that kind of meta level exposure of racism, and then look at the outcomes by race in terms of thinking about readmission? So kind of like your outcome being readmission, but kind of having this measure of a composite structural racism exposure, and then stratify by race. That is one way of thinking about it.
Just to clarify, if the outcome is the discharge rate, and we're going to stratify by race, and we do have, let's pretend that this person does have access to, let's say, neighborhood level structural racism composite, where would they put that in their model? Like, I
would say that as a primary predictor, but again, it
as a predictor.
Yeah.
No, I understand that you're not making recommendations for like a specific project. Of course, no, we all understand, like, there's no recipe for the perfect project, especially not when it comes to equity. We have to pay attention to the context, but I just wanted to make sure I understood your recommendation, like use it as a primary predictor of the outcome and then stratify those results.
Yes.
Okay, great. So I think on that very, very practical note, we will wrap it up for another Friday, so you all can have a little break before you have to do something at the top of the hour. Stephanie's put a fabulous other suggestion into the chat, so make sure you check out Pictal Health. I haven't seen it, but I will definitely take a look. And I cannot express how thankful I am, Dr. Cerdeña, that you joined us today. Amazing conversation. Really, really appreciated it. I will post your all the links. I recommend you read everything they write. There's a book coming soon.
Oh yeah, sure I will just say, so the book is more based on my work and collaboration with Latina migrant mothers. It is less on my racism in medicine work, but broadly considers these issues of how migration and traumatic histories are experienced by women who have settled and given up everything to build their lives in Connecticut. And it incorporates less of the quantitative work, but the more of the ethnographic work that I do. And so I'll share a little flyer that includes a discount code if you are just so inclined to read women's stories. It is another facet of what I do when I have my anthropological hat on.
That's great. There's several anthropologists and ethnographers here in the group today, so I'm quite sure it's on their Christmas list. So we'll make sure that you all get the flyer with the discount code, and I will wrap it up here. Thank you again, everybody, for coming. Always such a fabulous group of people, such a nice way to kind of spend a Friday. Have a fantastic rest of your day, everybody. Bye.